I'm an NHS GP. I did my GP training in the UK, and I work in Milton Keynes in the UK as an NHS GP. By way of additional training as well, I also have additional training in women's health. So I have a diploma of the faculty of the Royal College of Obstetrics and Gynecology. And I also have a diploma of the faculty of the Sexual and Reproductive Health. So I do kind of like additional women's health, contraceptive services, and also have a master's in public health. So I kind of have a lot of interest in health education. And yes, recently I started to do this Let's Talk Health series as a way of, kind of like educating our community about some common health issues. So today I'll be speaking on infertility, and it's just mainly to give you kind of like an overview. Because I work in the UK, all my references are going to be UK based. They're going to be how services are in the UK, how you can access services in the UK, but at least I'll also give you kind of like an overview, general overview, because though I work in the UK now, I did my initial medical training in Nigeria, so I had a little bit of a background of working in Nigerian system as well. So just to give like a general overview, and then we'll take it from there, and just to kind of like give us some tips on how to access the the services here. This particular topic is one that is very close to my heart, because not just being a doctor, but I actually had my own personal journey of infertility as well, that started way back in Nigeria. I had went through a test, investigation with my husband, and started in Nigeria, eventually in the UK as well. So it is a topic that is very, very dear to my heart. And it's something that I always love to share with people, because, I mean, I always say the power of a story, you can never underestimate. You can just never underestimate how somebody will be, will be blessed from your own story. So I'm always quite willing, to share my journey as well. So in between, I would try and give some examples of things we also went through as a couple. So to start with some facts about infertility. So when we talk about infertility, what we're trying to say is that obviously there is an inability to conceive, but despite frequent and unprotected sexual intercourse for at least a year. So I mean, some people may have the idea that, okay, once you get married, once you start having sex, it's just then automatic. But the way our the female reproductive organ is designed, we know we go through a cycle every month, and it is unique and it is different for every woman, but we kind of like have an average for most people. So some people will come and say, oh, I usually get my period every 28 days. Or sometimes they'll be worried because it was just late 1 day or 2 days. It doesn't necessarily have to be every 28 days, but that is just kind of like the average. And I think the most important thing is for each person to know their cycle. So just to give you, kind of like a brief overview, the very first 1 week after, so we usually say day 1, we start a cycle from your period, and the day your period starts is a day 1. So between the first 7 days up to 10 days, for some people, you have a period, some people have for 5 days, 4 days and all that. And then you then start this, so from that day 1 up until like day 10 up to day 14 is when around that time, some hormones will go up so that the ovaries can start to prepare the egg for release, and then the egg is released. Now, you may not be able to pinpoint exactly when that egg is released. There are some tips on how to kind of like test to try and estimate when the egg will be released. But most of the tests we do is just kind of to see where the hormone that goes up after the egg is released is what we use to test or to estimate whether an egg is released. Okay, then so the egg release happens around day 10, even up until day 18 for most people. And then the body then starts to get ready for pregnancy because the egg has been released. Now, if pregnancy doesn't happen, the hormone falls and then you have another period. So it kind of, you go through that cycle. So there is actually a very small window within each cycle where pregnancy can happen. And that is why a regular, frequent unprotected sexual intercourse is actually quite important because, like I said, you cannot pinpoint a particular day. Yes, if you monitor your pattern, you might be able to, and there are quite a lot of apps these days. You might be able to say, this is the period, and most apps will tell you this is the period. So if you are not having regular unprotected sex around that time, then you miss it because the egg, once it's released, can only stay for 24 hours, and then it kind of dies off. Whereas the sperm could stay up to about 3 days, 72 hours before dying off. So it is quite important that it's regular sexual intercourse and it is unprotected. And if a woman is under the age of 40 and the couples have regular unprotected sexual intercourse, it's been known that over 80% will conceive within a year of trying. So if you take a couple, the woman is less than the age of 40 and they just started trying for a baby, within a year, most 80%, 8 out of 10 will conceive. By the second year, the other half will also conceive as well. One in 7 couples in the UK, so approximately 3.5 million people, have some form of difficulty in conceiving, after this period. Now, there's different categories that we talk about. So primary infertility, you talk about the fact that these are couples who have never conceived. They have tried and tried, they have never conceived. So whether as a couple or in a previous relationship, they've never had any child. Secondary infertility will be if there has been a previous conception. So even if it's within the same couple, you've had a child together before and then you're now struggling to have one and you're having a lot of delay after that. Or maybe the man had a previous relationship and had a child with another person, or the woman has had a child or ever been pregnant before, then that is kind of like secondary infertility. It's quite important because the approach in terms of investigation and management may be slightly different. Then subfertility will be any factors that are reducing fertility. So there is not complete infertility. So for example, the couple, they are getting pregnant, but they are having miscarriages. So it's not infertility, but there is some factors causing subfertility in that scenario. So what are the possible causes? And I'll be focusing more on data from the UK. So when we look at infertility, like I said, is more of a couple that is trying to conceive. So the male factors generally account for about 30% of the causes of infertility. I'll try and give you some talk about the male factors later. Then in the woman, about problems in ovulation account for another 25%. Problems with the tube account for about 20%. Problems with the womb or structure surrounding the womb account for another about 10%. And in some cases, there isn't any identifiable cause. So you have investigations and it's just unexplained. And that could be up to about 25%. Then both male and female factors sometimes will account for about 40% overall. So what are the male factors that could cause infertility? So a lot of people do know, erectile dysfunction, low sperm count, and the poor quality of sperm. So there could be problems with the sperm, and there could be problems with the fact that you don't have enough sperm, or the quality of the sperm is not very good. Now, what are the things that would affect the sperm? It could be underlying medical condition like diabetes, smoking, excess alcohol would actually affect quality of sperm. If a man has a very high BMI, that could actually affect it. Over time, as we're getting older, actually the quality of sperm gets worse as well. if there's problem with the testicle, so if you've ever had a child in the UK and all that, a male child, you go for your 6-week check, the doctor will check to see if the testes are within the sac, because if they are not down there, then it becomes a bit of a problem. The internal body temperature is too hot for the testicle. So that's why every sperm that is produced, if the testicle is inside the body, would actually not survive. And that's why surgery is done to try and bring down the testicle back into the scrotum. If they have a congested vein, something we call varicoceles, with surrounding the testicle, then that can cause too much warmth for the sperm, and that can damage the sperm as well. Obviously, things like underlying medical conditions like cancer, if they've had treatment before, surgeries around the area could have caused damage. Infections, many people are familiar with mumps. Mumps infection is something that affects young boys and goes straight into the testes and can cause a long-term damage. Injury to the testes could cause that. Low levels of hormone, male hormone, could also be a problem. Some adult young men use steroids, when they are training in the gym and all that, and that has been known to have a detrimental effect on the sperm as well, and on the testicles. So then things like drugs and all that could, quite a lot of causes. It's just so many, and that is just when we're talking about male. Problems with ejaculation as well. So there could be a problem with the man not having proper erection, or the ejaculation is going the opposite direction, is actually going back into the bladder rather than going out through the penis, or delayed ejaculation. And that could be from the stress. It's been recognized that psychological stress actually affects sperm production, ejaculation, and all those kind of things. There could be underlying nerve damage that just doesn't allow the sperm to then be delivered correctly. There could be issues with, a man could have had a previous vasectomy. So they've gone and had sterilization, they've had the surgery, and that is the reason why they are not able to conceive. Then when we talk about the females, there could be problem with the ovulation, like I said. So there could be problems with egg production. And that is actually the most common cause in women. So you like, oh, the egg is meant to develop, get the hormone, come out, then get transported, and somewhere along the line, the sperm meets the egg. But in that cycle, there might be problem with the hormone that the egg is not released, and then or the egg develops, but just it gets arrested along the line. So there could be some people have conditions that make them to have what we call anovulatory cycles. So they're having cycles, but they are not actually releasing eggs. And one of the commonest one is what we call polycystic ovary syndrome. That is a condition where imbalance of hormones would actually stop the production. So the egg starts to get produced and develop, but then it doesn't get released. So it kind of like abruptly stopped the release of the egg. And I actually, during my investigation, I found out that that was the reason for my own, for us not being able to conceive. I was diagnosed along the line with polycystic ovary syndrome. Hormonal imbalances actually could also affect the egg production. So things like thyroid problems, stress hormones like prolactin, if your prolactin is very high, that could actually stop the egg from being released. Now, it's also been recognized that fertility generally, the quality of the egg decreases the older we get in women. So it declines from the age of 35, the eggs become, because with women, we are born with the total number of eggs that we're going to have throughout our lifetime. So it's already been determined when we were conceived for women. But when we get to puberty, the eggs start to get matured because of hormones that get released. So the predetermined number is there from the baby child. By the time we get to puberty, that number has actually decreased, and then it will keep decreasing as we're getting older. So by the age of 35, your ovarian reserve is much less. So that is why it's important to try and start early. And that's why we keep banging on about women over the age of 40 and all that, because not only do you have fewer eggs, the quality is actually much less. after that. So you have poorer quality of eggs. And then some people may have a condition where they then develop premature ovarian insufficiency. What that means is that you're going into menopause much, much earlier than the age that most people will go into menopause. So we've heard people that actually stop periods before the age of 40, and they didn't realize. Most people will go into menopause. The average in the UK is between the age of 48 to 53, thereabout. So, but anything below the age of 45 is considered as premature menopause. So if you stop periods all of a sudden, continuously for 12 months before the age of 45, that is premature. So some people may have that problem and they are not able to produce eggs. And there could be other conditions that are affecting the ovaries. Now, being too overweight can affect, so having a high fat reserve actually releases more hormone that affects egg production. Also, being too underweight. So if, so we've heard of athletes, people that have a problem with eating disorders and they're exercising too much, their BMI is too low, because you still need a certain amount of fat in the body to be able to produce the egg. So that, and even previous operations on the ovaries and all that, all those things could affect egg production. Also, the fallopian tube. So the egg has to be released, but it's released into the fallopian tube that carries it into the womb. If there is any problem within the tube, so the tube has been blocked because of infection, the tube has been scarred because of previous surgery. Some people have what we call endometriosis, which is a very painful condition that people have every month that causes scarring along the lining of the womb. So all these things could affect, could cause a problem in trying to conceive. Some other factors or risk factors are things like smoking. I've talked about stress in men, also in women as well. So relationship issues will cause reduced frequency of intercourse, low libido, and then some environmental factors have been found to also affect people when they're trying to get pregnant, things like pesticides or other chemicals, overexposure to these things. And some drugs, yes, prescription drugs, I've talked about cancer, chemotherapy and all that, and even recreational drugs, things like cocaine, excess alcohol and all that. So what do we do? When people have tried and they're not conceiving, obviously in the UK, they come to their GP. That is where your journey starts first. And I always say that, with infertility, it is both. At the beginning, it has to be both. Most times we find just the woman coming and saying, I'm the one trying. No, you have to come together. The man has to have their own appointment, and then the woman has to have the appointment as well. Reason being that for the men, the woman has a lot of tests to do. For the men, it is very important right at the beginning to get a semen analysis. Because like we said, look at how much, almost like 1/3 of the cost, is actually 1/3 of the course is from male causes. So the men has to have, a test done. They also have to have the appointment, have an history examination, and then they get referred. Because of the way the semen analysis is done, it's not just something you drop a sample in your GP surgery. You actually have to be referred because it has to be analyzed within 30 minutes of giving the sample. So you have to be referred to a special lab. So the journey starts with you booking an appointment, you getting referred to a special lab that will do it, and then they will contact you, give you the bottle, and tell you how to proceed with bringing the sample, and it has to get to the lab within a certain time. So depending on what the doctor finds, they might order some other blood tests like hormone profile in men, but for most men, is the semen analysis first. Is when the semen analysis then becomes abnormal, then other tests may then be indicated. Whereas for the female, there are 2 sets of bloods that we do. We obviously do the history, we try to get some information, trying to narrow it down to exactly what it could be. But just imagine all the causes I've listed and even many more. So it might look like there's a lot of steps, to jump through, but it is quite important because, like I said, there are quite a lot of causes that could be the case, and there's no way you would know until you do all those tests. So for the women, we do 2 sets of bloods. The first will happen within the first 5 days of the period, and it's just taking things like the baseline hormone, thyroid, and all those kind of things. Whereas for us to predict whether you've ovulated in a particular cycle, we do something we call day 21 progesterone. So that's the blood test I said will go up if you have released an hormone. And there's a certain level that we're looking for. So you'll be asked to actually time it to count when your day 21 will be. Obviously, if you have problems, you're not getting periods. So like people that have PCOS, some of them may not have periods for months. Then that we don't do day 21 in that case. Obviously, we just do the PCOS bloods. And once that is the problem, we do a sooner referral. You may also be asked to have swabs for infection and a baseline scan, first of all, to just have a look at the womb. And it is important to know that the tests run concurrently. So both have to be involved from the beginning. And then after that, in the GP practice, if you've had all your tests done, then a referral will then be done. So the referral is usually done for most people if you have tried for at least a year. But in some cases, we could do an early referral when there are, compelling reasons that are already telling us that, no, there is a problem here. So there's no point in waiting anyway. So for example, if the woman is older than the age of 36, if they're not getting periods, like I said, if they're not getting periods at all, that's an indication for early referral. If they had a previous surgery, previous cancer, previous treatments, obvious varicocele, in the men, then we know definitely there is already a problem. So we kind of get the baseline and refer immediately. But other than that, we usually say, oh, try for at least a year. If they're a much younger couple, do you feel that they haven't actually given it a go? So you ask them to try. And the referral is quite important to know that the referral is the couple. We're referring the couple. We're not referring the woman. It's only if we find out that, oh, okay, there is a major problem with them. For example, for the man, there's a problem with the sperm. Then the man, they also get a referral to maybe urology, for example, to if we've discovered something that we think, oh, urology have to deal with. For example, varicocele is treated with surgery. So it's congested veins that is causing so much blood to pull into the surrounding of the testicle and making the place too warm for the sperm. So in that case, I mean, obviously they also get a referral to urology where that has to be dealt with before getting a referral to fertility clinic. So in conclusion, I mean, the GP can refer once all the baseline tests have been done. And it is quite important that, we're proactive. So what I usually notice is that some people will come for the first test and then the man will get referred and then they will get tired and then they will come like 7 months after. Whereas your referral, at least here in Milton Keynes, all your tests have to be quite current. They have to be within the last 6 months. So if you look at all the things you have to do, it's quite important that you're actually, following it and making sure that you're actually doing the tests when you have been advised to do the tests so that there won't be further delay in terms of kind of like referring further. And to also know that these are just baseline tests, first of all. When you still get to the specialist, there's still some other tests, specialist tests that they would do. For example, checking if the tube, is patent. There is a special test that is done, but that won't be done in GP surgery. That's when you then get to see the specialist. So they will carry out the appropriate test and then they will then discuss, appropriate management in that case. So in a nutshell, I think basically that is what those are the kind of things that happen when we're talking about infertility, the kind of information. And if you have anybody struggling, it's always good to know that it's good to seek help and to seek help early. At least once you've tried for at least a year, much sooner. Like I said, if you are already having some problems, you're already over the age of 35 and you have tried even for 6 months, then it's good to immediately get that referral so that you can go and see your GP so that you can get those tests in place quickly and get some intervention done. Okay.
Well, thank you very, very much, Dr. Bolanle Adekanmbi. Thank you very much for that short and sharp talk, information, and that's what we have come to just learn. There's a lot there, and I'm sure if you have more time, there's a lot to unpack there. So I think I'm going to give him maybe, just maybe 5 minutes thereabout, to people if they want to ask maybe specific question before we kind of wrap up with a prayer. So if anybody has, wants to ask Dr. Bolanle any question, please, this is your time. Don't feel shy about it, please. So any question? Please feel free to ask question now. Okay, let me just check. Is that Lara?
Yes, I'm about to say something. Thank you very much for the education, for bringing all this, because as we know, many people are having this issue. But what help can we have? People struggling with infertility now that what are the help? What are the type of IVF that is there, and what does it cost for someone to have it done? Thank you.
Right. Okay. So the decision to, I mean, in terms of treatment, I didn't want to go into details with that because it would then depend on what your course, when the specialists then do further tests, they will now decide which treatment is appropriate for you. So for example, if they discover that, okay, there's no tube blockage, there's no problem with the sperm, the only problem is this woman is not ovulating properly. So the first thing they would do is to try and induce ovulation. So they will start with simple medication to just try and induce ovulation. And some of you may have heard about Clomid and all that. So there are some medications they'll just try for some cycles to try and see if they give some medication, the egg, just to help the egg to be released. So that is one part. It's only when that fails or they found out that actually inducing, for example, if the tube is blocked, there's no point in inducing ovulation anyway because the egg will still not get into that. Then yes, if they find out that you meet the criteria or the couple meet the criteria for IVF, so then on the NHS, it would depend on different areas, but at least in my own region on the NHS, you are entitled to NHS IVF treatment if you meet the criteria. So some of the criteria are maybe a bit quite strict. For example, your BMI has to be less than 30. You have to not have had any child from another relationship. So this couple must not have had any child, even if it's from another relationship, not this current relationship. So if you've had a child for somebody else before you got married to this person or you're trying with this person, then you won't qualify for that because they believe that child is still your child. So it's a bit more strict when it comes to NHS, and it's just all because of funding, because the funding is not that available. So if you meet the criteria, though, yes, you will be offered I think you can have at least about 3 cycles of IVF if you meet the criteria. There are some people, not everybody need IVF. Like I said, some people will just need the ovulation induction. Some people, if the sperm is poor quality or the sperm is there, but it's just not many, they might actually do what they call insemination. So they actually just help to get the egg and the sperm together and help with the with the reproduction in that sense. So just a little bit of assistance with that, and that is much less costly than IVF. But obviously, most people just know about IVF, but there are other treatment options. So for example, for somebody that has, maybe it's the man that has varicocele, sometimes once the surgery is done, the testes actually kind of improves. So if they've taken the problem away, so with men, they can produce sperm quite often. So it's not like they have a predetermined sperm. They actually produce sperm quite often. And so so they can, once you take out the problem that is affecting the sperm production, then the testicles will recover, and then they might be able to give it a bit of time, and then they might be able to, those couple may be able to, get to conceive naturally. So it all depends on the cause, what they find in a particular person. And that is why it may look like it's taking time, but actually you need to get to the root before you can then offer. It's only when they now decide, okay, we haven't actually found anything and this couple are still not getting pregnant, then they will offer you IVF. And if you meet the criteria on the NHS, it is free and you will have 3 cycles. Now, if you don't meet the criteria on the NHS, then the option will be to go privately. Now, the cost of that, to be honest, I can't quote from my head. I don't work in the private sector, but I think, I mean, from a few, what do you call it now? From few people that I've spoken to and all of that, it's quite expensive. You might be talking between £8,000 to, or let's say about between 5 and 10. I'm just giving a wide range. I'm not particularly sure about the specific amount, but for each cycle. So it is actually quite an expensive venture if you are not, if you don't qualify under the NHS. But if you qualify, you get it free of charge. And I think you get at least 3 cycles free of charge.
Okay, thank you very much for that. There is another question. What does medical compatibility mean for those who desire to get married?
All right, okay. So I think that when you talk about medical compatibility in terms of having children, in terms of infertility, trying to get pregnant, I would probably say the only thing we always get concerned about or we advise preconception is only about a sickle cell disease. Okay, so and it's just a case of most of us are from Africa. We know that sickle cell disease is quite common in the Blacks and all those kind of things. And the reason why it is important for you to know your genotype is just to prevent you having children that are SS. Okay. Other than that, there isn't any much in terms of, I mean, there is no test that will tell you whether you're compatible with this person or you're not compatible with that person. There isn't really any test that is done or is recommended. Really, the only thing we'd advise, I mean, because we know of the incidence of sickle cell disease and all that, we do advise, yes, you could make sure you get your genotype done. Because if you're AS and your partner is AS, you have, you know, that 50% chance of having a child that is SS. Is all about genetics. It's all about the genes that you carry, because you can't know which gene you're going to give 50% of your gene. Your partner is going to give 50% of the gene. So you don't really know which one. There is no way you can know ahead. So it's always good to prevent, because having a child with SS, yes, there are quite a lot of medical advancement these days, but it's always preventing that happening so that that child then doesn't have to suffer a painful condition, because AS people don't have any problems. They are just carriers. They don't have problems. They don't fall sick compared to a child that has SS. So when we talk about, if I'm counseling a couple that want to, you know, get married, if I wouldn't say there is any medical test that we do to see that you're compatible with that person or not. No, the only thing obviously is just making sure in terms of genetic diseases, it's just making sure that is the only one that comes to my mind. Obviously, there are other very serious medical genetic conditions that will be considered, but those ones will be quite obvious, and already you probably have that at the back of your mind before choosing a partner. But other than that, there isn't anything that we do in terms of medical compatibility. I think most people come to us as doctors once they're married and then they're having problems, you know, getting married, getting children. And if you look at all the causes that I've listed, there isn't anything that suggests that there was incompatibility between the man and the woman in terms of the causes that have been identified. I hope I've answered your question.
Thank you, doctor. If I may come in with that medical incompatibility, I think maybe what we are trying to look at is, are there tests like to check whether someone has hormonal imbalances that could affect the couple later when they come together, or there are sexual diseases that they might have contacted that could have failed them having children later. I think that is my own view about medical incompatibility.
Okay, yes. So we obviously, like, somebody that if you're not married and you're already having problems with your period, you're not getting periods at all, then it kind of so like I said, the most common cause in women is the ovulation problem. And one of the ways that you might know is your periods are all over the place. But if you're getting regular periods at least once a month, even if it's up to 28 to 32 days, that is still a regular period. Prolonged period is when it's more than 32 days. So if you're having a period you're not getting for 4 months, 3 months before you get married, yes, that is already telling you that there is a bit of a problem. So I think, obviously that person may want to, before getting married, go and seek medical opinion. But I mean, I don't think most people would even think about it unless it is very, very severe that, okay, you're not having periods for a prolonged period of time. So I have young people that in my clinic that their parents will bring because their periods they're not getting periods. And then we do the test and then we discover that they have PCOS and they might have treatment before, might start to have treatment. PCOS is a lifelong condition and all that. So they might start to have treatment. And if that person is then going to get married, I would expect that, oh, okay, the person will discuss with their partner that I actually have this. But it's always good to remember that PCOS is not all of them that won't get pregnant. So people with PCOS get pregnant even without any medical intervention, whereas some will have trouble getting pregnant. So that's why we just don't do tests before you get married, before you've tried, or before you've tried to have a baby. We just don't do a test before then. So, but like you said, yes, ovulatory problems can be a red flag that, oh, I might have problem in the future to get pregnant. If you've had a previous sexually transmitted infections, especially repeated ones, you've been treated, you've had antibiotics and all those kind of things before you get married or before you start trying for a baby, that may suggest that, oh, actually my tubes may get blocked, might be blocked. So some people may know, some people may not know. Fibroids, for example, fibroids are quite common in the Black community, but not all people with fibroids will have problem getting pregnant. It depends on where the fibroid is. Sometimes fibroid can affect people getting pregnant, but for some people, they wouldn't even know that they had fibroids until they're pregnant and then they're having a scan and then somebody says, oh, actually you have a fibroid. So we don't do any tests before people start to try. It's not, we don't do pre-couple. I think that might just be creating, I don't know how, what practices people are doing in different regions, but it's not something we would advise you to start testing before, to start saying, oh, will I be having problem? You try first. Yeah, if you feel obviously you're having problems with your period, then yes, you can go and see a doctor and see if there's any problem before you get married. And then I will expect that if you're getting married to somebody, you will tell the person that, oh, obviously I'm seeing the doctor for this because of this and that. But because there are no hard and fast rule, like I said, people may have had infections before, but we don't know whether it didn't really lead to any scarring of their tube. So we can't predict because you've had one infection in the past. I'll say definitely you're not going to have a baby. No, there is no way I can say that, because you may have had infection adequately treated. It didn't cause any problem with the tube. So there isn't any test that we recommend to do before getting married or before you start trying. So the approach is more, you start trying, you don't have success in trying, at least after 1 year, then we start to investigate.
Okay, thank you for answering that question. This is the final question. Does fibroids or the scars affect pregnancy? when tried through IVF, even after it is removed surgically?
All right, okay. So with fibroids, it depends on the amount, the size, and the place. So if you have a very, very huge, we've had people that have had their fibroids removed and they were able to get pregnant after that. So it depends on the kind of fibroid. If it's a very huge one, and that is where this is where individual situations come into place. Yes, like I explained in the courses, if it was an extensive surgery, then there's a likelihood that there will be a lot of scars, and then that can affect, fertility. But some people have been successful after the fibroid surgery to then get pregnant, even by IVF as well. Because what IVF does is that it kind of like helps to bypass that process of the egg being released, the tubes taking it, and then the sperm meeting it and all that. So what they do, they harvest the egg actually from once it's matured in the ovary, they harvest the egg in the lab, they put the sperm in the lab, so the baby is formed on or in the lab and then transferred back into the woman. And the womb is then prepared to receive that egg back into the womb. So if there has been scarring, from during the surgery that is holding on to that is affecting the tubes, then IVF will help with that. So it's not all cases. Yes, I've seen people that after removing the fibroid, then they were able to get pregnant, but some people have had to have IVF and they were able to get pregnant. But depending on the extent, yes, unfortunately, if it's a very huge fibroid, it can disfigure the womb, and that can affect the chances of the baby, even with IVF, of the baby then surviving within that environment.
Okay, I think that's all that we can take, in this hour. And we have been so blessed, by this information that you have given us, free of charge. We can't thank you enough. Can I ask everybody to just use your chat, the reaction, just to express your, gratitude and appreciation to Dr. Bolanle Adekanmbi for our time, to give us this, information. I'm sure each and every one of us, we've had one area that we can take back, to advise and to kind of give information to our relatives, even our children, friends, and colleagues that are struggling in any area of infertility. I'm sure there's one particular area that we have been blessed today. So we want to say thank you very, very much, Dr. Bolanle Adekanmbi. God bless you as you make yourself available, to bring your medical expertise to bless the community. It is an honor, and we are so blessed, this morning, for giving us your time. So the time that we have left, I'm just going to share the screen, our prayer board, and then we just pray generally, from what we have received